if you have mixed them together, they form the colloid from the time you mix it. And then you don't have the control on the particle size. So this is provided in a liquid form, and this is provided in a powder form, lyophilized powder. Because tin does not like oxygen, and anything dissolved in saline will have oxygen there, and that will affect the quantity of tin over the time. So it is lyophilized and freeze dried, and this is a solution. So you transfer 5 ml from here into this one, mix it properly, you have a tin fluoride solution, and then you're taking half a ml from here, adding that one to your technetium. Technetium 1 to 1.5 gigabecquerels or 20 to 30 millicurie. You take it in 2.5 ml of syringe, 2.5 ml of saline in a 5 ml syringe. Put them together and expel all the bubbles. You don't want any bubble there. We call it big bubble, big trouble. So don't have any bubbles inside. Expel all the thing and then put that on the rotator for one hour. So that 1 hour mixing will give you a particle size which is 1.2 to 2.1 microns. And this micron size particle are very ideal for white cells to take it up by phagocytosis. Okay? Phagocytosis means nothing but, they will gobble them up. Pac-Man. So once you have done your technetium labeled colloid, then you mix that one to the patient's blood, mix it, take all the bubbles out, and then put it back on the roller again for 1 hour. So this process allows the blood cell to take the colloids and then lock them all into the white cells. So then you just dilute it with 10 ml of saline, centrifuge it for 10 minutes, and then separate the plasma from the cells. So less activity you have in the plasma is better. So that all the things that you fed the blood, it is there in the white cell, and that's what you want to do. And the advantages here, you need small amount of blood, like 7 to 10 ml of blood, and then in terms of separating the cells, that step you don't need to worry about it. You can take the whole blood and then do that labeling, and it is far less expensive. So in the United States, one vial of the Seratec is sold for $2,000, and we are selling. The tin colloid kit, you can buy it for $50. That's what we pay. I don't know what is the cost of that over here.
So once you've reconstituted it, can you use it again now? And
within the same day, you can use it up to 4 hours after making the mask. But later than that, you can use it. But in practice, we want to use it within 2 hours.
So you do how many? You do a lot of patients?
Most of the time, one patient at a time. Some days, some emergencies or something, we do one in the morning, one in the afternoon. So, okay. So the test of the truth will come out, once you measure the amount of radiation you have in the plasma and in the cells. So that will tell you, whether the labeling occurred properly. Otherwise, I will blame the blood. Okay?
Blame the donor.
Donor. Who is the donor?
He's gone.
He's gone. He had enough of it. I want to reassure him, we can give the blood back to him. We don't want, we only wanted it for demonstration. So many patients, when it comes back to the question of injecting their own blood back into their system, some do it, some say, we can't accept the blood back because some religious concern, like the Seventh-day Adventists or some
Jehovah.
Christian religion, or even the Jews,
I think the Jehovah's Witnesses.
Jehovah's, they don't accept the blood back in form of a transfusion or their own blood going back. So this created a bit of a problem. So one of the questionnaire we have for the patients, you have to say, you have to ask them and clarify, we are going to do this to your blood and then we are going to put it back to you. Would that be acceptable? If they say no, then there is no point in doing the test. Doing all this procedure and then finally you don't want to end up rejecting that one. So it is good to know who, by practice of religion or their own sort of belief, if you don't want this practice of getting that back to your system, then don't do it. And others are scared. Oh, I don't want blood transfusion for me. But we have to reassure and clarify it's your own blood. We only added some radiation to it, just like any other scans that we do, any other CT or X-ray, just the amount of radiation, but much less radiation than a CT or an X-ray. So we have to convince them and tell them and explain to them what you're doing, so they exactly know what is happening. At the end, there is no problem. Majority of the cases they will accept. They will go ahead with whatever is the medical procedure and recommendation. But in cases where they don't understand this, or for religious reasons, then you don't want to waste your effort and all those things.
In our country there's a high prevalence of HIV.
Right.
And a lot of the centers don't want to do the labeling, the normal white cell labeling. So they use a kit. Amersham has got there's a kit, a leucoscan.
The NCA-90.
Okay. So they sometimes use that, and with this method you have these less manipulation with the blood. You've hardly really done much, whereas with the white cell labeling you're spending a lot of time.
Yes. I think less the manipulation, less exposure you have, the chances of infecting yourself. And these are all the merits and problems you have.
It's available to you?
It's very expensive. They use it in the private practices. I don't use it. I use this.
It's available in the country.
It's available in the country, but they do use it for specific patients. They would order
So
them.
how many more minutes?
Is that the labeling seems to be quite good with that? You just take blood and you just add it and you mix it. It's quite.
Yeah.
You like it?
You
You
don't?
like it?
She just said take it.
Yeah.
Just said take it. Incubate it and
That means because of old age, very old people,
white blood cells.
And I suppose if you follow the aseptic technique and follow the procedure, there's a minimal risk of exposure, I would say.